This presentation, developed by the Department of Medicine at Santosh Medical College, explores a complex case involving dyspnea, ophthalmoplegia, and rapid neurologic decline. We will engage in a staged clinical reasoning discussion where the diagnosis is intentionally withheld initially, allowing us to observe how reasoning evolves with progressive case disclosure. Our panel includes Dr. Proxipitis, Anupam as the doctor, DeepSeek 3.2 as the resident, Grok 4.2 as the consultant, and GPT 5.4 as the expert. This approach highlights how new data reshapes diagnostic thinking, emphasizing the dynamic nature of clinical problem solving. Let's begin by outlining our learning objectives for this session. By the end of this discussion, you will be able to organize a staged approach to rapidly evolving acute presentations, localizing cranial nerve and respiratory findings without premature diagnostic closure. We will track how the differential diagnosis change with each new data release and recognize when a favored explanation no longer fits the examination. Additionally, you will learn to identify management priorities even when the diagnosis remains uncertain. This case specifically highlights the dangers of airway bias, the influence of alcohol history, how ICU complications can confound, the importance of cerebrospinal fluid findings, and the value of late exposure history in solving neurologic puzzles. Now, let's look at how this session will be structured to achieve these objectives. This session is designed as a single script with multiple reasoning passes and repeated diagnostic revisions. First, the doctor reveals the case in stages, presenting new information sequentially. Following this, we will pause to consider what truly matters at that moment. Next, the resident will provide their initial interpretation, offering a first pass assessment of the situation. The consultant will then critique this interpretation, focusing on prioritization and safety aspects. Afterward, the expert will synthesize the strongest working frame based on the available data. Finally, teaching pearls will capture the pivotal learning points from each stage. Our aim is not to provide a single perfect answer, but to demonstrate how clinical reasoning adapts as new data. In this first stage, we are introduced to a 47-year-old man found breathless in his car, reporting a sensation of tongue swelling and difficulty breathing for about 2 hours. He has been consuming alcohol for several hours, with a history of heavy daily intake and multiple prior emergency visits for intoxication, along with chronic thrombocytopenia and prior delirium tremens. Notably, there's no fever, sore throat, rash, vomiting, or facial/lamp swelling. Upon arrival, his blood pressure is 139/132, pulse 14, respiratory rate 22, and oxygen saturation is 91% on room air. He is afebrile, diaphoretic, awake but intermittently inattentive, with slurred and muffled speech, yet still speaking full sentences. Initial treatments with epinephrine, diphenhydramine, and steroids have not improved his condition. This initial presentation raises several immediate questions for consideration. At this audience, pause before we hear the first interpretation. It's crucial to consider the most important immediate frame for this presentation. Are we looking primarily at an airway allergy or angioedema, given the reported tongue swelling sensation? Could it be a non-allergic upper airway problem, or perhaps a pulmonary or aspiration event, especially with alcohol history? Alternatively, is this a toxic or metabolic process in a heavy alcohol user? So, it is essential at this juncture not to let the patient's self-reported label become our diagnosis. Carefully weigh these possibilities as we move to the resident's initial assessment. The resident's initial read of the case notes that the failure of anaphylaxis treatment lowers confidence in histaminergic angioedema. Hypoxemia, tachypnea, and inattention strongly suggest a systemic process. Muffled speech could indicate either airway pathology or neurologic dysfunction. And the patient's significant alcohol history raises concerns for intoxication, aspiration, or metabolic disease. Based on this, the leading differentials include alcohol intoxication with aspiration pneumonitis or respiratory depression, non-allergic upper airway obstruction, pulmonary embolism or cardiopulmonary event, and neurologic causes like seizure-related or nutritional disease. Proposed next steps include a rapid focused airway examination, direct visualization of the oropharynx, blood gas, chest radiograph, and laboratory workup, along with oxygen, thiamine, and readiness for advanced airway support. Now, let's hear the consultant's critique of this initial approach. The consultant acknowledges the resident's good breath in considering the differential diagnoses, but emphasizes that airway visualization and safety must come first. The resident correctly recognized that non response to epinephrine is a major clue, kept upper airway pathology high on the list, and proposed direct examination rather than relying on labels. However, the consultant points out weaknesses, too much emphasis on a broad medical workup before clarifying the airway, and the risk of anchoring on intoxication or aspiration too soon. It is crucial to distinguish between histaminergic and non histaminergic processes. Consultant priorities are immediate laryngoscopic airway assessment, early ENT and anesthesia awareness, targeted metabolic workup in parallel but not before airway decisions, and preparing for controlled intubation if deterioration occurs. In high acuity cases, the order of thinking is as critical as the list of diagnoses. Let's now hear the experts' synthesis of this stage. At this stage, the expert synthesizes that a severe brainstem predominant Wernicke encephalopathy is the best fit. The best unifying frame so far is that this isn't typical allergic angioedema. The muffled voice combined with dyspnea suggests supraglottic or bulbar dysfunction as the key threat. While alcohol intoxication may be present, it doesn't fully explain the entire bedside picture. Alternatives remain weaker because there's no visible edema, rash, or clear trigger. Pulmonary causes don't fully explain the localized throat complaint, and pure intoxication is an incomplete explanation for the voice change. The most important move now is to clarify the airway source directly, keep neurologic mimics in mind, and avoid diagnostic closure before the examination evolves. Remember, a bulbar syndrome can initially present as a sensation of tongue swelling. Now, let's move to stage 2 with new doctor input. In stage 2, new doctor input removes edema from the frame and introduces a striking neurologic sign. A repeat examination reveals no facial or visible tongue edema and an unremarkable neck examination with clear lungs. Direct airway assessment via flexible laryngoscopy shows limited abduction of the vocal cords during phonation, but no supraglottic or glottic edema. Crucially, new key data includes the patient's inability to direct either eye in any direction. The complete blood count shows leukopenia at 3,800 per cubic millimeter and platelets at 58,000 per cubic millimeter. The basic metabolic panel is normal and blood ethanol is 209 milligrams per deciliter. A chest radiograph shows low lung volumes with faint pibasal opacities. Respiratory distress worsens, necessitating intubation. CT head, Connecticut venography, and MRI brain show no stroke or mass lesion. This new information significantly changes our perspective. With the emergence of complete bilateral ophthalmoplegia, a new localization problem has appeared, dramatically changing the case. We must now consider if this finding localizes to the brainstem or cranial nerve pathways. Can intoxication alone adequately explain these new eye findings? More importantly, what diagnoses can unify ophthalmoplegia, the previously noted bulbar dysfunction, and the patient's ongoing respiratory decline?
So, what is this process affecting?
As the examination becomes more focal and specific, our differential diagnosis must narrow considerably. Let's see how the resident pivots their reasoning in response to this critical new data. The resident's pivot in stage 2 shifts the working diagnosis towards a severe nutritional or metabolic brainstem syndrome. Their conclusion is that acute bilateral ophthalmoplegia combined with encephalopathy in a heavy alcohol user strongly suggests Wernicke encephalopathy. The limited vocal cord abduction is interpreted as bulbar or brainstem involvement, and the negative neuroimaging is considered supportive rather than exclusionary. At this point, the differential includes Wernicke encephalopathy severe ethanol intoxication as a contributor, but not a full explanation. Other toxic or metabolic encephalopathies, and autoimmune or inflammatory brainstem processes if thiamine response is poor. The immediate plan focuses on high dose intravenous thiamine without delay, supportive ICU care post intubation, electrolyte and magnesium attention, and deferring further studies until after treatment has begun. Next, the consultant will offer their critique of this revised approach. The consultant agrees that Wernicke encephalopathy is a reasonable consideration, but stresses the importance of staying disciplined about localization and treatment intensity. What was strong here was recognizing ophthalmoplegia plus encephalopathy as a Wernicke pattern, not letting a negative MRI exclude the diagnosis, and starting treatment immediately. However, caution is still needed. Alcohol and ethanol levels can explain inattention, but not complete ophthalmoplegia. Bulbar involvement makes the syndrome more unusual, and the differential should remain open to anti-GQ1B spectrum disease and other mimics. Consultant emphasis includes specifying the thiamine regimen clearly, repleting magnesium phosphate and potassium, using daily sedation interruption with serial cranial nerve examinations, and reassessing the diagnosis if recovery isn't prompt. A plausible diagnosis is not the same as a closed diagnosis. Let's now hear the expert's synthesis. At this moment, the expert agrees that severe brainstem predominant Wernicke encephalopathy is the best fit. This fits well because both encephalopathy and complete ophthalmoplegia are present. Bulbar involvement can be interpreted as an atypical brainstem extension, and a negative early MRI does not exclude the diagnosis in this clinical script. Alternatives are weaker because pure intoxication is an incomplete explanation, structural imaging is negative, and airway edema has been ruled out directly. Therefore, the most important next move is to treat with full dose intravenous thiamine and magnesium, track eye findings and bulbar function closely, and keep rare inflammatory mimics in reserve if recovery fails. This is where the case temporarily looks solved. We will now move to stage 3 for an ICU reassessment. In stage 3, an ICU reassessment provides a cleaner neurologic examination under the Wernicke hypothesis as sedation is held. The patient now follows simple commands by nodding, and pupils are equal and reactive. However, eye and brainstem findings reveal he still cannot move his eyes vertically or laterally, and his eyes do not move with passive head rotation. Corneal and cough reflexes remain intact. Motor examination shows intermittent tremulous movements in both forearms, with limb power at least 3 out of 5 in all 4 limbs, and light touch appears intact. Deep tendon reflexes are preserved and symmetric, but cerebellar testing cannot be done. High dose thiamine and folate have been started, and he is being monitored for alcohol withdrawal. These findings help us refine our understanding of the localization. Under the working diagnosis, the localization summary in stage 3 still points toward ocular, motor, and bulbar pathways with preserved basic reflex architecture. Findings supporting a central or brainstem frame include complete external ophthalmoplegia, absent oculocephalic eye movement, bulbar dysfunction with vocal cord abductor limitation, and preserved pupils and corneal reflexes. Findings that do not fit a diffuse peripheral paralysis are the presence of reflexes, at least partially preserved limb power, and intact sensation. The team stayed with Wernicke because the alcohol history strongly supports thiamine deficiency. Imaging remains unrevealing. Some neurologic interaction is still present, and treatment is urgent and low risk. Remember, a working diagnosis survives only until the next stage proves it wrong. Let's now consider the management priorities given this evolving picture. Our management priorities in stage 3 are structured around a severe but potentially reversible nutritional brainstem syndrome. For disease specific treatment, we continue high dose intravenous thiamine, folate supplementation, and magnesium and electrolyte repletion. Monitoring includes daily sedation interruption, serial cranial nerve examinations, and close observation for improvement in eye movements and mental status. However, open questions remain unresolved. Will the neurologic deficits improve promptly? Could an anti-GQ1B spectrum disorder still mimic this pattern? And would new examination findings force a change in localization? Good management can still be built on an incomplete diagnosis. Let's explore the key educational insight from this stage. This stage is particularly educational because the team had a plausible syndrome, an actionable treatment, and negative structural imaging. Yet the case was still not settled. The deciding factor was how the examination evolved over time. This highlights that negative imaging does not definitively end a neurologic case. Serial examination is often the most powerful test in a rapidly changing neurologic presentation, providing crucial dynamic information. We must always be prepared to adapt our thinking as new clinical data emerges. Now, let's consider what happens in stage 4 with clinical deterioration. Stage 4 brings clinical deterioration and a significant confounder. The patient's neurologic state worsens sharply. The following day, off sedation, he no longer opens his eyes on command and does not withdraw to pain. An electroencephalogram shows continuous low amplitude alpha activity, which is not a typical encephalopathic pattern. Simultaneously, pulmonary and inflammatory changes occur. Fever rises to 39.7 degrees Celsius, tachycardia develops, hypoxemia worsens, and chest imaging reveals bilateral lower zone consolidation. C-reactive protein is elevated, lactate rises modestly, and he's treated for aspiration pneumonia. This introduces fresh diagnostic noise as he develops hypotension soon after CF3 axon, raising concerns for a drug reaction versus sepsis versus autonomic dysfunction. These new developments complicate the diagnostic picture. During this confounder phase, the differential diagnosis evolves, fragmenting into overlapping neurologic, infectious, and hemodynamic explanations. The old Wernicke framework still persisted because it could explain ophthalmoplegia and coma, and sepsis might simply be worsening an already vulnerable brain.
Additionally, sedation and critical illness could cloud the examination findings.
However, new concerns arose. The alpha pattern electroencephalogram was not typical for ordinary toxic metabolic encephalopathy, and the decline felt more severe than expected for treated Wernicke alone. Clinically, attention was split between septic shock, a drug reaction, and structural brain injury. The true neuromuscular diagnosis remained elusive. A confounder can be genuine and still significantly delay recognition of the main diagnosis. Let's see how the senior synthesis addresses this complexity. During this period of deterioration, the senior synthesis emphasizes the need to treat sepsis and shock, but without letting them fully explain the neurologic syndrome. Immediately, aspiration pneumonia and distributive shock physiology must be managed with broad supportive ICU care and hemodynamic stabilization, alongside ongoing high dose thiamine and electrolyte replacement. What still does not fit the current explanation includes the alpha pattern electroencephalogram, the severity of neurologic decline relative to the initial explanation, and the earlier combination of ophthalmoplegia and bulbar dysfunction. The teaching correction here is to treat the ICU complication but keep the neurologic localization problem alive. We must reassess the working diagnosis if the serial examination continues to evolve away from it. Never let a new problem erase the unexplained findings that came before it. Let's consider the teaching pearl from this stage. This teaching pearl reminds us that confounders are dangerous precisely because they are often true. Aspiration pneumonia was real, septic physiology was real, and hypotension after ceftriaxone was real. The critical mistake would have been allowing those truths to fully explain a neurologic pattern that was still changing in a different direction. When the clinical examination evolves, it is imperative to revisit the primary syndrome and reevaluate the initial diagnostic framework. This vigilance prevents diagnostic closure based on plausible but incomplete explanations. Let's move on to stage 5, where new doctor input on hospital day 3 reveals significant changes. On hospital day 3, new doctor input reveals a dramatically changed examination, breaking the previous model. The patient now exhibits loss of pupillary, corneal, cough, and gag reflexes. There is no withdrawal to painful stimuli, though occasional spontaneous toe movement is noted. Crucially, reflexes are now absent throughout. Repeat, CT head imaging remains unchanged. Cerebrospinal fluid analysis shows one nucleated cell per microliter, no red cells, and protein at 53 milligrams per deciliter. Glucose is 140 milligrams per deciliter, with a simultaneous serum glucose of 278 milligrams per deciliter after steroids. Significantly, there is no albuminocytologic dissociation. These findings fundamentally challenge our previous Wernicke hypothesis. The previous framework no longer fits because the serial examination has moved from a brainstem predominant syndrome to a diffuse descending areflexic paralysis pattern. What now argues against the earlier diagnosis is the progression to generalized areflexia, loss of multiple brainstem reflexes, failure of the expected trajectory under treatment, and normal repeat structural imaging. The cerebrospinal fluid contributes no inflammatory picture and no albuminocytologic dissociation, offering no support for a classic Guillain-Barré pattern. The syndrome now visible on serial exam includes cranial neuropathies first, respiratory failure, descending flaccid weakness, areflexia, and a near brain death mimic.
The fastest way to change a diagnosis is to follow the examination honestly.
This leads us to a diagnostic reset. With this diagnostic reset, botulism now rises to the top as pattern recognition favors a fulminant toxin-mediated descending paralysis syndrome. Botulism fits the script now because of bulbar symptoms early in the course, complete ophthalmoplegia, including absent vestibulo-ocular responses, progression to respiratory failure, loss of brainstem reflexes with generalized areflexia, near normal cerebrospinal fluid, and unchanged imaging. Earlier alternatives weaken because the Wernicke framework no longer explains the full progression, and classic inflammatory neuropathic patterns are not supported by the cerebrospinal fluid.
Structural imaging also remains unrevealing.
The implication is that urgent botulinum antitoxin should be considered without waiting for confirmatory testing, and brain death determination would be unsafe before a reversible toxic paralysis is excluded. The case has changed from which brainstem syndrome is this to is this a reversible paralytic mimic? We now await the final clue. Stage 6 reveals the final crucial clue that confirms the direction of our diagnostic reset. Late history obtained from the patient's mother provides vital information. He often eats perishable food, which is sometimes left at room temperature for several days. This simple exposure question solved the case after multiple high-level diagnostic pivots. The final diagnosis is foodborne botulism, which perfectly explains the early bulbar complaint that mimicked tongue swelling. It accounts for the complete ophthalmoplegia and respiratory failure, the descending flaccid paralysis with areflexia, and the near brain death picture with normal imaging and near normal cerebrospinal fluid. This emphasizes the importance of a thorough history even when complex neurological patterns are present. Given the final diagnosis of foodborne botulism, several urgent actions are necessary. We must immediately notify public health and arrange botulinum antitoxin urgently without waiting for confirmatory testing. It is also crucial to send serum, stool, gastric contents, and any relevant food samples for analysis. Supportive, prolonged intensive care, ventilation, autonomic monitoring, and pneumonia treatment are essential. This case matters because botulism can mimic airway disease early, Wernicke or brainstem disease in the middle phase, and even catastrophic brain injury or brain death late. Our 3 final lessons are to follow the serial examination even when the first diagnosis feels elegant, not to let real confounders erase unexplained earlier findings, and to ask exposure questions late if they were missed early.